We'll start. We'll start, madam.
Yes, sir.
Good evening. Welcome to today's thyroid. We'll start with the prayer. Yes. Good evening to all. Welcome to today's session of thyroid clinics organized by the Indian Thyroid Society. So we have been successfully conducting for the last 6 months the thyroid clinics every month. And thanks to the coordinators, Dr. Pramila Kalra and Dr. Roma Pradhan, with guidance from President Dr. Krishna Shadri sir, Indian Thyroid Society President, Dr. Arun Menon sir, Secretary, Dr. Mini Pillai Madam, Treasurer, and the coordination team of Dr. Chitra Selvan, myself, and Dr. Kanavi. Next. So just to remind you that the Indian Thyroid Society is successfully running the Thyroid Research and Practice Journal. So you can go online and it's a good journal coming out with quarterly issues. So please consider your submission. You can also consider becoming a reviewer for the Thyroid Research and Practice Journal, which is the flagship journal of the Indian Thyroid Society. So today, Thyroid Clinics webinar, we are going to have a case presentation and a monologue and a quiz. So the case presentation will be on the topic of non-recurrent laryngeal nerve, surgeon's enema or paradise, and monologue will be on thyroid eye disease, followed by the quiz. To discuss about the case presentation, I invite our moderator, Dr. Kulranjan Singh, additional professor, Department of Endocrine Surgery, King George's Medical University, Lucknow. He is MS, MCH, and he is CMR, DHR, PhD fellow also. He is co-editor of the journal Endocrine Surgery South Asian Perspective. He has got multiple ICMR and intramural projects and ICMR faculty PhD grant of around 50 lakhs. Over to Dr. Kulranjan Singh to introduce the topic and the speaker, Dr. Ritesh Agarwal.
Good evening. Thank you, Vijay sir, for that introduction. Good evening, office bearers of ITS and all attendees of this webinar. To introduce the topic per se, we all know that thyroid surgery is amongst the commonest endocrine procedures performed in today's times. And voice change along with hypocalcemia happen to be the commonest morbid effects, after effects of this surgery in a substantial number of patients. And when we look at what are the causes of these voice changes or loss of voice or deterioration in the voice quality, the non-recurrent laryngeal nerve or the surgeons not being kind of proactively looking for non-recurrent laryngeal nerves or thinking about this particular possibility may be a reason for substantial number of voice changes in our patients. And ITS has been gracious enough to think of this as a topic for webinar, as it is often overlooked. And Dr. Ritesh Agarwal, if I have to introduce him, is the apt person to speak on this topic. And if there was a single person to exemplify, or an endocrine surgeon to exemplify the proverb which said that a surgeon should have the eyes of an hawk and an eagle, hands of a lady, heart of a lion. Luckily, lion is not the most courageous animal, because surgeons should not be as courageous as they are taken by the society. Dr. Ritesh should perfectly exemplify all these factors, and it's his hawk's or eagle's eye that actually picks up all these non-recurrent laryngeal nerves. So every now and then he keeps posting these pictures in our endocrine surgery groups, and we just wonder whether all these patients with non-recurrent laryngeal nerves go to Dr. Ritesh Agarwal specifically, or the rest of us are not looking after them. Dr. Ritesh Agarwal is an endocrine surgeon who's practicing at Leelavati Hospital and Bombay Hospital. And to add to his feathers in the caps, he can be the modern day Indian Warren Buffett or present day Jhunjhunwala, who is deeply into stocks. and he's very popular amongst all the medical community for his knowledge about stocks and all the advices that he gives. With this, I'll hand over the podium to Dr. Ritesh Agrawal, who has a case to present, and then we'll take the discussion forward. Dr. Ritesh, please take over.
Thank you so much, Dr. Kulkarni. So, Dr. Kulkarni is very close friend, and we both did our MCS together. And he knows me a lot. So, whatever he says, I can't contradict, because if I contradict, he will put some other logic, and I know how good he is speaking on the podium also. So, I will never counter him. Now, starting my presentation. Are you all able to see my slides, please?
Yes,
Thank you.
yes, sir. Continue.
Yes, Ritesh.
So first of all, I would like to thank Indian Thyroid Society for giving me this opportunity to speak on non-recurrent Lallian nerve, whether it is a surgeon's enigma or a paradise. I would like to thank President Sir Dr. Krishna Seshadri, coordinators Dr. Pramla Kalra and Dr. Roma, and moderators for today Dr. Vijay Bhaskar, Dr. Kulkarni and others. Thank you so much for giving me this opportunity. So starting my presentation. Let's revisit the normal anatomy of the recurrent Lallian nerve first. What is the recurrent Lallian nerve and why it is known as recurrent Lallian nerve? Larynx or our voice box contains few cartilages and few muscles, which are supplied by two nerves. One is the recurrent laryngeal nerve and one is the external branch of superior laryngeal nerve, which produces voice. More important is the recurrent laryngeal nerve because it supplies all the intrinsic muscles except cricothyroid. It is known as recurrent because it reverses its direction and runs upwards from downside. From the vagus nerve in the neck, when the vagus comes inside the mediastinum in the chest, it gives a branch, the recurrent laryngeal nerve, which loops around the arteries. On the right side, it is the subclavian artery. On the left side, it is the arch of aorta. So the course of the right nerve is small. The course of left nerve is larger. And then it runs in the neck in the tracheoesophageal groove. Between the trachea and esophagus, there is a very fine line where these nerves run. The problem is that in the right side, because the subclavian anatomy is variable, so the nerves take a different courses in many patients. Sometimes they are vertical, sometimes they are oblique, and rarely they are non-recurrent. It is very important to understand the anatomy and embryology of these nerves. The recurrent laryngeal nerve is branch of the sixth pharyngeal arch. So if we see the normal anatomy of the recurrent laryngeal nerve, are you able to see my video, please? Thank you. So if we see the recurrent laryngeal nerve runs vertically in the tracheoesophageal groove and goes behind the common carotid artery to loop around the subclavian artery. This is the common carotid artery which was pulsating while I was operating. This was just a day before video, which our assistant shot during parathyroid surgery. So whatever it is, either thyroid with thyroid is here, here is the trachea. So either thyroid or parathyroid, the nerves run vertically or obliquely in the tracheoesophageal groove and goes behind common carotid to loop around the subclavian artery. Now, let us revisit some of the embryological developments of the subclavian artery. It develops from the 7th intersegmental cervical artery. Right side, the origin is many times variable. If we remember, there is a dorsal aorta also on either side in the embryo. So the proximal part of the dorsal aorta is diminished and only the distal part of dorsal aorta remains, which along with the 7th intersegmental artery gives rise to the subclavian artery on the right side. On the left side, there is usually no such variation. So right side variations are more and right side non-recurrent laryngeal nerve is more. Suppose if the subclavian artery is arising from the proximal part of the dorsal aorta, then it becomes an aberrant origin of the right subclavian artery. So therefore, there's nothing to loop around. Hence, vagus gives nerves branch directly in the neck, which runs transversely this is the non-recurrent nerve. Sorry, this is the recurrent nerve which is looping around the subclavian artery, and this is given by the vagus nerve in the neck directly to run transversely. It is known as non-recurrent Langerhans nerve. Here, the subclavian artery is aberrant origin and coming directly from the arch of aorta, not from the brachiocephalic artery as is usual from here. So in such cases, the nerve arises directly in the neck, and here it is liable to be damaged during thyroid surgery. So this aberrant origin of subclavian artery is known as arteria lusoria. It runs behind the trachea and esophagus, and hence the esophagus is compressed between trachea and the artery, causing dysphagia, which is known as dysphagia lusoria. Here it is very common to find non-recurrent Langerhans nerve along with dysphagia lusoria. As a surgeon, as Dr. Kulkarni has already told, that most common and most important complication for thyroid surgery is injury to the recurrent Langerhans nerve, which leads to voice change and hoarseness. No patient wants that his voice should be changed after surgery, and that is why patients usually present very late also because of the fear of losing voice. So if there is an injury to recurrent Langerhans nerve, either it is non-recurrent or recurrent, they may have a hoarseness. This I always love that I love to be a surgeon. Why? Because during surgery, it really gives me a thrill. It is really very exciting to do a surgery. Thyroid surgery demands high skills to find out such kind of nerves, either recurrent or non-recurrent, and save them properly with all the branches also. Thyroid surgery is a very challenging thing. I love to be a thyroid surgeon, and we perform under pressure. So finding a non-recurrent Langerhans nerve is really a paradise for the surgeon, not an enigma. I love to find the non-recurrent Langerhans nerves. Till date, in our data, we have found 12 non-recurrent Langerhans nerves out of more than 3,000 thyroid and parathyroid surgeries. The prevalence is usually 0.5% in the general population, usually on the right side. When left side it is present, it is very, very rare and associated with situs inversus. Though it is many times present with right aberrant subclavian artery, but sometimes there may be subclavian artery normal origin, but there shall be a non-recurrent nerve. It arises from the vagus nerve in the neck. If you see, this is a photograph of the surgical field after removal of a specimen. This is trachea, that is the blue color, is written by blue color. The green arrow is showing the non-recurrent Langerhans nerve entering directly into the cricothyroid junction, and it is arising from the vagus nerve in the neck only. So this is a non-recurrent nerve. Here we see, this is another video of non-recurrent Langerhans nerve. So in this video, I have traced the non-recurrent Langerhans nerve. We did a preoperative CT scan. The CT scan was showing aberrant origin of right subclavian artery. Hence, we were careful that we may encounter non-recurrent Langerhans nerve during surgery. We found it, and we traced till the vagus nerve. Confirmed with the neuromonitor. This black pointer is the invasive neuromonitoring that we use regularly. It really helps. When it touches the nerve, it stimulates the nerve, and it gets signal which are heard as a beep on the monitor. So how this neuromonitoring works, short videos also. Invasive intraoperative neuromonitoring. If you see the green thing, there are electrodes fitted with the endotracheal tube. These electrodes are fixed at the level of vocal cords. Then we put the surface electrodes. So after fixing the surface electrodes, we check the monitor for proper attachments. So that's how the circuit is complete. So identification and preservation of the recurrent as well as non-recurrent lesion is very important and essential. We always do a preoperative contrast CT scan. This is our protocol. Careful dissection is essential and mandatory. If we do not find any kind of nervous tissue in the tracheoesophageal groove running vertically or obliquely, we should always look for a non-recurrent path, that is the transverse origin of the nerve, and if present, then we should trace it and save it. Neuromonitoring really helps, that we have shown also in the videos. It confirms the origin of the nerve as well as the integrity. So take-home points, preoperative CT scan in all patients, though I agree that some people may differ with this approach, but in my personal approach, I found it really useful. Careful dissection, as I already told, in the thyroid bed to find the recurrent and non-recurrent nerve. Sound knowledge of anatomy is very important to know all the variations of the recurrent lesion nerve and save them. And if possible, if available, then use of neuromonitor. So thank you so much. And last, I always like that if I was not a doctor, then what would I been doing? Either a taxi driver or cook, or you people know what else. Happy Valentine's Day. That is coming in 2 days. Thank you so much, ITS again. And I am ready for any kind of questions and queries.
So thank you, Ritesh, for that wonderful presentation. I'll just add a few more points which I thought would be pertinent for this, taking this discussion forward. So as Dr. Ritesh rightly pointed out, we should be suspicious enough so that every patient can potentially have a non-recurrent laryngeal nerve. So if we look at the true incidence, it's between 0.3 to 0.5% across all thyroid surgeries. But if we analyze the literature properly, probably this is once again an underestimation. Because if we look at the incidence of all these vascular malformations that Dr. Ritesh was talking about, it occurs in almost 0.5 to 2% of the general population. And if we assume that a general population also presents to us with a goiter, then the incidence of such patients should be much higher than what is actually reported in literature. So in fact, as more and more intraoperative neuromonitoring has been utilized, almost even some literature can be shown that the incidence of non-recurrent laryngeal nerve can be as high as 6%. So that's a huge number. And what is important, that both recurrent and a non-recurrent laryngeal nerve can exist in the same patient. So what remains to be known is, suppose someone who has both a recurrent and a non-recurrent laryngeal nerve, will cutting through or damaging one of them result in voice changes? I don't know the correct answer to that. But yes, probably it may result in some change in the voice character. So every case that we operate upon, we should be vigilant enough to think that this particular individual is having or harboring a non-recurrent laryngeal nerve. And occasionally this can be bilateral too. So my question to Dr. Ritesh is his strategy, as he said that the recurrent laryngeal nerve normally travels in the tracheoesophageal groove vertically, does he suspect it if he doesn't see a vertical nerve-like structure, or he thinks that it is present in all cases because he normally picks up more non-recurrent laryngeal nerves than any average endocrine surgeon? Dr. Ritesh?
Thank you so much, Dr. Kulranjan. See, as you told that we have to be vigilant enough in the thyroid, but while doing the dissection, non-recurrent may coexist with the recurrent lesion nerve. I agree. Sometimes there are certain anastomotic branches which are given from the recurrent laryngeal nerve directly to the vagus. So they should not be labeled as a non-recurrent, or they do not come into the category of non-recurrent now. They are simple anastomotic branches. We have seen separately also. We have analyzed them, and I have posted the photographs also, as you would be knowing. Many times there are multiple anastomotic branches between recurrent laryngeal nerve and vagus. We have to save all of them, because even if they are not motor, there might be sensory fibers running, and which may lead to some sensory changes in the vocal folds or dysphagia also after surgery. So we have to save all the nerves and all the anastomotic branches, as well as any nervous tissue which we are able to identify. In one of my previous case, I had shown in the photograph, the non-recurrent branches were also 2 branches. So it is not necessary that non-recurrent will be a single branch only. There might be multiple branches. We have to save all of them to get the best results after surgery in terms of voice or any kind of swallowing dysfunction.
So if I were to summarize this, Dr. Ritesh, am I right in saying that don't cut any horizontal cord-like structure unless you document that the vertical non-recurrent laryngeal nerve is present? Can that be a take-home message from this
Yes.
webinar?
Well, rather than cutting anything, it's better to save all the structures. Apart from that, tissue you have to remove. Simple thing is that remove only the necessary tissue and save all the other structures in the thyroid bed so that you can save all the branches which are hidden of the recurrent or non-recurrent.
So, matlab, a lot of our attendees today are probably non-surgeons, but we have to actually cut across many horizontal structures when we retract the lobe medially. So a take-home message for all surgeons should be, don't cut any horizontal structure which is definitely not a vessel or the middle thyroid vein, and preserve it till we actually identify a recurrent laryngeal nerve.
Fully agree.
So, in your presentation, what you said, Dr. Ritesh, was all patients should be subjected to a non-contrast CT.
Contrast CT.
A contrast CT. So do you stand by it? You may be practicing in Bombay and there are all classes of patients going to all kinds of patients. Should that be a dictum to actually kind of avoid landing in such a trouble? That all patients should undergo a CT, because the radiological parameters when a patient should be subjected to CT are quite limited. And most of us actually don't do. So
I agree, because place to place practice differs. However, doing a CT scan saves us a lot. Apart from finding vascular anomalies, there's so many other information which we get from CT scan, which is not possible to get from sonography. Like sometimes detached thyroid nodules in the mediastinum or large water extensions which are not seen on sonography, are easily evident on CT scan, plus any vascular encasement also. See, all these things are collaborative. If I keep myself in place of the patient, I want the best. I don't want to take any chance, because surgery is a big thing for any patient. So before surgery, I should be careful. I should be I should be knowledgeable in all the aspects, what I'm going to do and what I'm going to find. That is the crux. That's why I do CT scan in all the patients. But
so I'll
practice
throw
different
another
different.
question to Dr. Ritesh, and even for all the endocrinologists. Do most of us perform the ultrasound ourselves?
No.
So pre-operative, before taking the patient for surgery, are you in a habit of doing the ultrasound yourself? Or do you believe in the concept of surgeon-performed ultrasound?
See, nowadays there are so many centers for doing ultrasound by surgeons, because ultrasound machines are falling under the PCP Act. So I don't want to go into any kind of medical legal obligation. Hence, I don't do any kind of ultrasound now. I am well versed with the sonography techniques and used to do sonography previously, but now I don't do anything, any sonography on my own.
So why I tried to get this point about what Dr. Ritesh routinely does, all of us actually can do it ourselves or get our radiologist to do it. Even someone performing a good ultrasound can actually pick up these vascular malformations. So what can be typically exemplified by a Y sign on ultrasound, where both the subclavian and the carotid along with the brachiocephalic, in case there is no vascular abnormality, that is typically seen as a Y sign, which has been. So if we are actually kind of if we can kindly get our radiologist's attention to it, that when they're sending the patient to us with an ultrasound, they try and pick up these abnormalities on the ultrasound itself, or we as surgeons can actually learn how to pick up this Y sign on performing the ultrasound ourselves. And this can be typically seen on the side where recurrent laryngeal, or the let's say the right side where the non-recurrent laryngeal nerve is more common compared to the left. So this is another thing that I would differ from Dr. Ritesh. And of course, these has medical legal implications, but we can actually give more and more patients the benefit of this particular modality. And ultrasound can also pick up these vascular abnormalities in a vast majority of the patients if we actually look for it. And then if a patient has these vascular abnormalities, then definitely we should be cautious enough or more cautious in those patients to do the best for the patient. So another thing, what was evident from your presentation was, do you suggest that IONM should be used in all patients? It does help us in such challenging situations, but what would be your suggestion to other surgeons or the audience?
I already wrote that intraoperative neuromonitoring is useful. It's a really useful tool. Use if available. It's very costly thing. For me, per patient, it is costing extra 27K. So if the patient is affording, if the patient is ready to pay, then use it. If it is available, use it. Otherwise, there are definitely limitations are always there.
So what I want to get across to the viewers, as Dr. Ritesh said, intraoperative neuromonitoring is a luxury in today's times, more so in our country, which is available only in bigger hospitals and amongst the bigger government-funded hospitals. We do have it in our institute. Dr. Roma Pradhan also was amongst the pioneers in this particular, using an IONM. But what we should understand, that this cannot be replacement for a good surgeons or the eagles and hawks eye that Dr. Ritesh and Dr. Roma have, and other surgeons, of course, on the ITS team. So that is no replacement for identifying the recurrent laryngeal nerve or the non-recurrent laryngeal nerve. But what I would add to or put forward in words of what Dr. Ritesh was trying to say, there are many cord-like structures which run horizontally, which may or may not actually be one of these anastomotic nerves or even the non-recurrent laryngeal nerves. So to add to the current advantages or scenarios where IONM may be helpful, I would definitely say that these IONM can be useful for us to confirm whether that horizontal cord-like structure is a recurrent laryngeal nerve, a non-recurrent laryngeal nerve or not. So it does have an advantage, but we should not use intraoperative neuromonitoring with the intention of picking up a non-recurrent laryngeal nerve in all patients. That should not be the strategy. It's not going to help us with that. That message should not grow across to those in training. IONM is an adjunct which can and should be utilized if available and if the patient can pay. If it costs 27,000 in the private sector, even in the government sector, where even if we have to charge the patient just for the tube alone, a tube costs around 16,000. Additional, if for per patient, if we charge for the machine also, it will actually increase the cost of the surgery. So if Dr. Ritesh charges 27,000 additionally for an IONM, for in a government hospital like ours, a thyroid surgery in total costs around 2,500. So this addition of such gadgets may make things more complex, and I would definitely support its use in certain scenarios, but not in all cases. Now I hope that Dr. Ritesh agrees to what I said.
Only one thing, there are always some points which we differ. Dr. Ritesh does not charge, it is the hospital which charge, and I don't get anything from the intraoperative neuromonitoring. Thank you.
Okay, so there are no questions in the chat box that can Dr. Roma Pradhan add something? We have a few more minutes remaining.
Yeah, we just have 1 minute. We have already talked a lot about this non-recurrent laryngeal nerves. But I must say that intraoperative neuromonitoring does help. And the point is, we do not know beforehand, because we have to be prepared. You do not know what you will be facing while you are operating. So we use it for all our cases. And I think it's an informed decision with the patient that, yes, we are using. And in a corporate hospital, it's a little different from what we practice in government hospital, I must say. So the quality cannot be taken, we cannot go back on that, I think.
So luxury may be the wrong word. Definitely, even if it doesn't do
quality
any good
is more
for
important. Luxury, you won't say it a luxury for us, but
yeah,
it's important.
If it definitely does not do any good to the patient, I would definitely agree. It gives us a good night's sleep after a surgery. That I would definitely agree. From the surgeon's perspective, it makes our life a lot easier. Apart from that, just to summarize it, if I think I have another 2 to 3 minutes to summarize it, as a surgeon, this is one entity that we should always keep in our mind, that any patient that we are operating upon potentially harbors a non-recurrent laryngeal nerve, and to look for it, the commonest dictum would be don't cut any horizontal cord-like structure which is not the middle thyroid vein before we identify a recurrent laryngeal nerve in its normal position. And as Dr. Ritesh also agrees to, the non-recurrent laryngeal nerve, recurrent laryngeal nerves, or what we call the anastomotic nerves that are present in the thyroid bed, all of them should be preserved to give the best outcome to the patient. And CT scan, if possible, a contrast CT. If not, we should always inquire about such vascular anomalies from a radiologist friend, or if we are performing the ultrasound ourselves and if these things are not given in the report, we should always look for this Y sign that can be picked by all of us. And during surgery, if we have access to intraoperative neuromonitoring, it is again one of those indications which is traditionally not listed in the for the advantages of INM. I personally and all of us think that in such a scenario, an INM would be of help.
Yeah, thank you so much. Yeah, I think we should close the session. Dr. Bhaskar Reddy sir, you can take. Yeah.
There's just
There's one question in the
chat
chat box. Yeah.
Yes.
In spite of INM, how often do you get nerve paresis in your practice? So the golden figure is 1 to 2%, and hopefully Dr. Ritesh and Dr. Roma also agree to that. However, I think the real incidence is much higher than that. Temporary voice change is quite common, which normally disappears within 4 to 6 weeks. And we don't brand someone as having a nerve palsy unless the voice change or the vocal cord mobility is restricted for more than a year. With this, I hand over the podium to the Dr. Vijay sir. Thank you.
Thank you, Dr. Kulranjan. Thank you, Dr. Ritesh and Dr. Roma Pradhan for the excellent presentation and clarifying about this importance of identifying the non-recurrent. We move on to a monologue on thyroid eye disease, which is an important accompaniment and association with thyroid disease. Previously called Graves' ophthalmopathy, now we know that thyroid eye disease can be associated with other conditions like hypothyroidism also. To talk on this important topic of thyroid eye disease, we have Dr. Suryasnath Rath, who is Network Director of Operations, LV Prasad Eye Institute, Bhubaneswar, and he is expanded ophthalmic plastics and thyroid eye clinic at LV Prasad Eye Institute. He has authored 74 index publications and also edited a textbook on thyroid eye disease published by Springer. So over to Dr. Suryasnath Rath.
Thank you, sir, for the kind introduction. I'll try to share my screen. So can you all see this screen at the moment?
Yes, sir. You go to full screen, sir.
That's right.
Yes, yes.
Are we good? Right. Thank you so much. First of all, thanks for the invitation. I would remember one of my teachers earlier telling me that the most, you learn the most when you attend meetings which are from other subspecialties and other super specialties, because you tend to be more attentive. And it was wonderful to see some of the anatomy and the kind of challenges we as surgeons face. Very nice to hear that. I'll come to my topic on thyroid eye disease, and I'll try to take through a little bit of a journey, but try to focus more on what is sort of a newer aspects into management of thyroid eye disease. I'll start with this trigger patient who I call a young female presented, and the picture on the left is exactly how she presented 2007. I call her my trigger patient because she is one of those who probably triggered my interest into the disease. And it took us quite a while to understand this. We were dealing with Graves' orbitopathy, thyroid eye disease, and many other names that are there. But essentially, we did decompression surgery, and we really didn't hope that the picture on the right up is actually what we thought we could probably relieve her of her exposure symptoms, and maybe she could just go out in the sunlight. Believe me, this is how she was after 5 years. And essentially, after the decompression surgery, we had done a right eye penetrating keratoplasty, essentially a corneal transplant and a cataract surgery. And I don't know how many of us would tend to believe that she had 20/50, let's say 6/18 vision in the right eye, which was really a dramatic turn of events. So we move on to what we take as, let's say, the diagnosis of thyroid eye disease is essentially where we sort of follow the Bartley and Gorman criteria. And what it says is that you have to have eyelid retraction as a central component of to diagnose this as eye disease. But in addition to eyelid retraction, you may have, again, thyroid dysfunction, exophthalmos, optic nerve dysfunction, and even extraocular muscles. But in case you don't have eyelid retraction, you will have to keep the central component as thyroid dysfunction, and then any of the other three criteria. So the point I'm trying to make is, if you really don't have eyelid retraction and you also don't have thyroid dysfunction or abnormal regulation, you would have a little difficulty in designating that particular case as somebody who has thyroid eye disease. Like most other diseases, thyroid eye disease also has mild, and then you have moderate to severe, and what is very severe. This is the European group's classification, but very simplistically, essentially mild is where there is no impact on daily life. But on signs, essentially, that means you have a little bit of proptosis, eyelid retraction less than 2 millimeters. And most of the times, all we do is a little conservative therapy. In selenium deficient areas, there is also literature to support that probably selenium helps. The more important one, and this is one to I spend a little more time, moderate to severe, very interestingly, has been clubbed together. And most of the time is much more disease which is far more florid from the retraction, from the proptosis, or even from the diplopia or the double vision, which may be constant or intermittent. But important because most of the time, this is the time when you could possibly change the course of therapy. So that's why moderate to severe. And if that was not enough, we actually have sight-threatening disease. And that could either be because of the compression of the nerve, quite talked about, or we call it DON, dysthyroid optic neuropathy. You may have microbial keratitis or exposure, like the picture at the bottom left, or you also have intractable glaucoma because of very high pressures not managed with medications. So all of these can actually be sight-threatening disease that you have to intervene, and most of the time it's an emergency management. We also need to think about what exactly do we mean by activity. And then there is a clinical activity score, and we'll also find surrogates of how to look at the clinical activity score. But essentially what I mean is, the picture on the left is how the patient comes to you. We give the typical UGOGO IVMP protocol, and then we see that he comes to this in a few months' time, essentially showing that he has actually progressed after the IVMP was stopped. But what you want to finally reach is finally he becomes inactive, and this is the sequel you're faced with, and you need multiple rehabilitative surgeries to take him there. But what activity means is, in the first 6 to 18 months, or possibly 6 to 12 months, you have a huge opportunity to change the course. And that is what this particular picture shows, that you would probably look at therapies which could change the course, plateau down the course of disease in such a way that he doesn't have the kind of intractable sequelae that leads to more rehabilitative. And this is a very fundamental paradigm shift in management of thyroid eye disease. Don't take it to a stage where you'll need multiple rehabilitative surgeries. This is the, I talked about the moderate two. We'll touch upon a few. Now, this is a lady who had a very severe eyelid retraction, as you can see. And despite the fact that she had, she didn't need any systemic glucocorticoid therapy. All we did was Kenacort or triamcinolone injections into the muscle, into the superior rectus LPS muscle. And there you see the kind of change. So essentially, retraction is because of the muscle change, and specific injection into the muscle made this change possible. And she needed no other surgery later that. So this is very, very new, and has been helping a lot in taking care of pure eyelid retraction types of patients. How do you come to know? And this was what I was alluding to. You have the clinical activity score that we talk about based on the soft tissue signs. But here we have the imaging on MRI, and there are several parameters. What we tend to use, and is a picture on the arrow in yellow, shows the signal intensity ratio. That means you calculate the ratio between the intensity that comes out of the muscle, a particular muscle, and compare it with the, let's say, a temporalis muscle, which is outside the orbit. And that gives you the SIR, or the signal intensity ratio. But also alternatively, you have T1 and T2 relaxation times, which help, and they corroborate very well with the activity of the disease. So by doing a combination of MRI and also looking at eyelid retraction, or in a thyroid eye disease patients, we tend to know what is the activity of the disease based on deep imaging of the orbit. UGOGO protocol that we normally follow was revised in 2021. And there were a few changes that came to our rescue. And one of the important one was you could actually shortcut or actually give only 6 cycles of intravenous methylprednisolone and add immunomodulation. And that was very helpful because we had our own set of challenges of actually going through the entire 12 cycles of therapy of UGOGO. But more importantly, we also faced that while there was a significant and a good response, a lot of patients, around 20 to 30 patients, actually tend to relapse after you've stopped the intravenous methylprednisolone management. I wanted to show this particular lady who actually presented with very active disease in the beginning. And apart from the IVMP that we gave, we actually added her on oral azathioprine, and we settled down with the disease. She had several attacks of dysthyroid optic neuropathy in the beginning, but she settled down, and finally we did a decompression surgery, and that the picture on the right tends to show. So a lot of times we are doing this now for the sustained response. We are bringing in immunomodulation with the help of a rheumatologist, and that helps a lot. Orbital radiotherapy, again, another modality to change the course of the disease. To quickly show the kind of results is the picture on the top actually shows how the patient presents. And this one, remember, he's got a thyroid dysfunction, but look at, he doesn't really have any eyelid retraction to begin with, but he definitely has soft tissue signs. And these are the ones which are the problematic ones because they don't have exophthalmos. And that's why there is a bigger risk of dysthyroid optic neuropathy. Anyway, he had a high CAS score. We started him on IVMP, not much of response. The middle picture shows his CAS scores were still about 4, and we added radiation. Radiation is actually on a low dose. We have shown that 2000 rads is what you give in 10, but various regimens. What we tend to give is alternate day. So about 10 to 20 days, we complete the therapy, and then we followed up with another 250 milligrams of IV methylprednisolone. And a lot of actually patients who have muscle disease and have double vision, they tend to do very well with radiation therapy. Every management has its own things. And particularly in India, one of the challenges we face is a lot of patients are diabetic, hypertensive, and we generally would not like to give radiation in people less than 35 for the long-term risk of second cancers or cancers later in life. This particular patient developed radiation retinopathy, which had to be managed by my retina colleagues. Coming to the most severe form, which is a sight-threatening disease. And this one, we'll start with what is the exposure type. Now, usually the picture on the top tends to show that a patient presents with, we call it SPKs, but that's a short form for superficial punctate keratopathy. You essentially have corneal erosions. But a lot of us feel that this is predominantly because of structural damage. But you realize that this is not only structural damage. There is a lot of even cytokine changes, osmolarity of the tear film, which are all changed in thyroid eye disease. And that's why it presents as corneal erosions. The worst ones actually progress to microbial keratitis, as you see in the middle picture. And these ones you need to definitely intervene in the form of surgery. And the picture at the bottom is actually where after the decompression surgery has been done. And there is definitely a big response. There is a corneal scar that you don't see in a frontal picture like that, but she definitely has a reasonably good vision after that intervention. Another patient who was from the northern part of Bengal during COVID times, and there were a lot of these patients who were presenting, and again, needs emergency decompression. But I want to probably leave you essentially with our, what we looked at was our own series of patients who had corneal breakdown, both with microbial keratitis and also the pure corneal erosion types. And we found that this particular complication actually happens, or very severe disease happens both in inactive and active disease. Several have both compressive optic neuropathy and also have corneal breakdown. But most important is only decompression doesn't help. You have to take care of the eyelids. You have to start antimicrobial therapy. You have to start on immune modulation if the patient is active. And that combination tends to aggressive approach, tends to save a lot of eyes from going into perforation. We got this was about a 35 patient series of 50 eyes that we treated over 10 years, and a fairly good about 87% globe and vision salvage that we could achieve by a very aggressive management strategy. Dysthyroid optic neuropathy is the most commonly talked about, and usually the patient would present in a decrease in vision, a color vision drop, and the disc edema, and apical crowding. The MRI picture on the right actually tends to show you that there is a significant hyperintensity and a crowding of the muscle. And essentially the CT scan findings, which tend to show the apical crowding I talked about. We also have a few other, let's say the proximal optic nerve sheath, the optic nerve stretch, which is called the stretch optic neuropathy, which is a fat predominant disease. All of these exemplify dysthyroid optic neuropathy. This particular patient from the Northeast presented during COVID times, dysthyroid optic neuropathy despite IVMP and rituximab, non-responding, and ultimately after 4 months, we actually had to do a combination of medial and lateral decompression, and very good results and complete restoration of vision and color vision in both his eyes for this particular patient. Another patient who presented with a different type of a dysthyroid optic neuropathy, which was like a stretch, and that you see by looking at the posterior pole of the globe, which looks like a apical. It's like a triangular shape, that angulation that comes because of the pressure. And again, we first did decompression, followed by mycophenolate, which was kept on for a few months. And we had a good recovery, though not entirely in the right eye because he had already lost some optic nerves by the time we intervened. A little bit about our own experience and challenges. We were always faced this one particular observation in the clinic, that whenever the patient had diabetes along with thyroid, it was always a much bigger problem because of various things that we had to face. And this particular series showed us that the risk that the patient could actually develop dysthyroid optic neuropathy is actually double. And if you have diabetes along with thyroid eye disease, and also the fact that you could also have recurrent problems, dysthyroid optic neuropathy, and also bilateral. So you could have a risk of losing both your eyes because of this. A very, let's say, I think group effort, because when we took out this paper on series of diabetes and thyroid, there were 3 different groups in India who published this, and they were all independent of each other at the same time in 2020 to 2021. And this is where we actually, several of us came together, and Dr. Pramila Kalra helped us on the to give her inputs on the endocrinology. But what it really led us to help, that there were multiple, I would say, intersection points between thyroid dysfunction and diabetes, which I'm sure all of you already know. But the key thing that we found was these are the kinds of disease which should definitely be treated in a multidisciplinary clinic setting. There were feedback that we also came to know that probably metformin was a better one. But of course, you could always switch to other drugs like insulin if there was hypoglycemia. But there was elements of, probably a low-grade inflammation which was playing a role. But key thing that I want to highlight is if it was moderate to severe disease, you had to put in more of immune modulation of methotrexate, azathioprine, or whichever you would comfort with to control the disease for a sustained response. But more importantly, if there was a site-threatening disease, these were the patients where early surgery followed by immune modulation was better to do. So this was a new treatment algorithm that we suggested in this particular. A little bit about targeted therapy. In the world today, there is a lot of talk about anti-IL-1. So essentially, it is when an IGFR-1R antibody, monoclonal antibody called teprotumumab is very much, and it's creating a lot of, shown a lot of promise in the US. Unfortunately, is not available anywhere outside the US. Our own experience has been with tocilizumab, and this particular young engineer actually presented with the picture on the left you see. And he, after the right picture, actually shows that after we had already treated him with IVMP. But essentially, what we switched was we moved on to subcutaneous tocilizumab, anti-IL-6. And this we chose to give subcutaneously. And fair enough, you can see after we gave 8 injections, and we have been following this protocol-based 8 injections of subcutaneous. Several reasons there. Literature has both IV and subcutaneous. We chose subcutaneous because there seems to be promise of extrapolating and giving this drug by the possibly a physician or somebody under supervision by the patient, so it need not have to come again and again. The other big thing is anti-IL-6 tocilizumab has a decade of experience in rheumatoid arthritis, and the safety margins of the drug is very, very good. Another patient who presented with, again, dysthyroid optic neuropathy, and this particular patient also had a very good response. He developed a new double vision, of course, but his clinical activity settled down. And this particular picture is very nice because those of us from the fundus picture, there is disc edema in the top one. The bottom one shows that it is settling down. But the MRI image on the right, I was talking to about the high signal intensity, and is finally actually settled down, and the low signal intensity seen after treatment with tocilizumab. Surgery, of course, we always, prefer to do endoscopic decompression surgeries for particularly patients who come with dysthyroid optic neuropathy. The benefits are predominantly morbidity. This particular patient, actually, the response of vision after endoscopic decompression is dramatic. This particular patient changed from 20/80 and 20/60 in right and left to 20/30 and 20/40 in the very first day after surgery. And within 1 week, he was 20/25, his color vision had reverted back. So that's the kind of change that you can do if it is endoscopic decompression. Another patient, again, which tended to show the same kind of change, and the morbidity itself is a big advantage why we would actually prefer doing endoscopic decompression. I would probably spend a little more time on the fact that inactive surgery disease is rehabilitative surgery, and a lot of people actually come by the time they have already gone into an inactive stage. And this young girl, a nurse, and this is the kind of disease she had. And after surgery, both right and left of eyelid and orbit, that's her after. This one is what I had already shared. But most of the times, we tend to do a staged approach to surgery. That means we do orbit, then we do muscle after several months, then we do eyelid. Now, that takes a lot of time. What we have been increasingly doing is actually simultaneous strabismus and orbital surgery, and sometimes even eyelid surgery, to decrease the time. And there is a lot of talk in the ophthalmic, let's say, of the oculoplastic, I would say, field about trying to do simultaneous surgeries, and the results are very, very promising. That's my, the last slide that I have. And essentially, I would put it as whether it is a recalcitrant disease or it is something that we face day in and day out, we have multiple modalities of treatment. We have corticosteroids. We have a combination of adding corticosteroids and immune modulation, azathioprine, MMF, methotrexate, all have been talked about. We also have radiation that I talked about, and of course, surgery. And at the same time, there has been targeted therapy. Rituximab was always there. Tocilizumab is a new kid in the block. But the most promising that we unfortunately don't have here is teprotumumab or Tepezza. But I think in every particular disease, it is important to actually feature in what is the severity of the disease, bring in the activity, whether you are treating a disease within the first 6 to 9 months where it will make a difference, because loading steroids in a patient who's inactive is not going to make a difference. And more importantly, you understand that if you have old age, if you have diabetes, if you have male gender, when the thyroid disease has come in, or if you have radioiodine that has been used, all of these could be risk factors, and multiple risk factors could significantly change the course of the disease. And essentially, we have to all do this. That means customize and make a potpourri or a cocktail which suits our particular patient. And that's what we are all here for. Thank you so much, and for your patient listening.
Thank you, Dr. Rath. I think it was an excellent predisposition, and you have done excellent work on thyroid eye disease. So I have just one question that initially the UGOGO came out with this guideline that they recommended to use IV methylprednisolone pulses along with MMF right from the start. And then thereafter, some studies came that they are not very useful giving MMF along with IV methylprednisolone. So is it still your routine practice to give MMF along with IV methylprednisolone, or you give only methylprednisolone pulses?
That's a very good question, sir. Thank you so much. You're absolutely right that the guideline I showed is a 21 guideline. And interestingly, a little background to that is there was not much of literature. This was predominantly led by Dr. George Kahali. But essentially that the MMF, the evidence towards MMF helping in the sustained response was not as much. But anyway, they had gone ahead and extrapolated that. So the other important part of the background is after this has been used for several years, a few studies have been retracted with MMF, and also a few mixed response has come where some have been happy, some have not. I think the key element that we have taken away from this is we tend to cut short and use sometimes MMF, but more often methotrexate and azathioprine, whichever suits us more. And that I leave it to the rheumatologist. And that is where I think it has helped us a lot. So it talks about MMF for some reason, but it is essentially one of the other two or any of the other immune modulations along with IV corticosteroids, which is of more of benefit.
Straight away start some immunomodulative therapy along with glucocorticoids.
Yes.
Any other questions from the panel members? What about this topical drops and all, sir? You find it useful?
The topical drops are actually, like I said, most of the time, patients, when they are active, they would complain of gritty sensation and difficulty when you go out. So lubricants are the most common things to use, even in mild disease and definitely in moderate. So good amount of lubricants, tear substitutes, and especially nocturnal lag of thalamus is quite common. So people tend to have a lot of exposure when they are sleeping at night. So you should probably use a lubricant ointment at night time. But other than that, I think we would probably not use a lot. I think the key thing is also to identify people who are at risk of corneal erosions. And sometimes in our country, because the microbial infections very quickly get affected, so there is a significant risk of vision going down. So in case of a corneal breakdown or microbial infection, you obviously have to use a topical intensive therapy.
Last question, sir. Role of selenium. When do you use selenium in these patients?
This one is actually, to be honest, again, has been used in mild, in fairly well-controlled trials. But essentially, while the takeaway is good, the general thing is you need to know whether your particular patient population is selenium deficient or not. We also have the challenge that at least, so most of the time when we are faced with a patient with mild disease, I would tend to give selenium these days for the benefit that at least is not causing any harm. Let me use that. We have the limitation of not having a pure selenium preparation, but a combination preparation that is available is something that we would tend to give.
Thank you, sir. Thank you very much. There are no further questions. Thank you very much for joining us.
Thank you.
So we move on to the last part of today's thyroid clinics on much awaited quiz. So to conduct the quiz, first we will have the DM quiz, Dr. Ritesh Agarwal. Again, Dr. Ritesh, we have two Dr. Ritesh here, and he will do the quiz. I will just go through the quiz rules. To participate in the quiz, please click on the button, attend quiz button given on the screen, which is being live streamed. So who are on live stream, please click the attend quiz button. The quiz will be conducted through a platform called Slido. Preferable to use a laptop for ease of experience. Whole duration of quiz will be for 5 minutes. The quiz master, Dr. Ritesh, will display case or description of question and do not go back on the screen. So I would like to introduce the quiz master, Dr. Ritesh Agarwala, who is a consultant endocrinologist at Manipal Hospital and Narayani Fetal Medicine Center, Bhubaneswar, Odisha. So he is secretary of Odisha Endocrine Society. He's got 13 publications in international national journals, and he's got Young Endocrinology Awardee 2019 from the Economic Times. Over to you, Dr. Ritesh.
Thank you, Vijay sir, and I would like to thank Ganvi ma'am, Kalra sir, Sadri sir, and the entire team of the ITS clinic for allowing me to be a quiz master in this session. So the flow of the quiz will be like this. We will go with the DM question. After the 10 DM question, Vijay sir will be discussing about the general quiz we did for our normal PG students. And after that, we will discuss about the DM question answer. So I am sharing my slide.
Madam Ritika, you
Yes,
let
sir.
us know
Please
when
wait
to
for
start.
5 minutes now, sir.
Yes. We'll just wait for 2 minutes and because people have to join on the platform, we'll just wait for 2 minutes.
Okay, okay, sir.
Ritika, you let us know when we can start.
Yes, sir, sure.
Because the live streaming people will be joining on the Slido platform. So we'll just wait for 2 minutes.
Ritika ma'am, also let me know when I will change the second question or third question.
Sure, sir. I will.
Ritesh, this is the correct presentation. It says answers.
Madam sir,
It says ITS quiz practitioners.
we can start that.
No,
Can I share?
this is the correct question.
Yeah. Can I share that slide also, sir?
No, we don't need the answers. It says quiz practitioners quiz. So this is the one, or is it
This is
the
the
DM?
DM question, sir. DM question.
Okay, sure. You share it. You can start, madam. Ritika, madam.
Sir, just give me 2 minutes, sir. We'll start
Okay.
it.
Sure.
Sir, let's start.
Now, Ritesh.
So, good evening, all the participants. So, this is the GM quiz session what we are conducting. After that, we will discuss the general quiz questions with answer and followed by the DM question quiz and answer. So, Ritika ma'am, please guide me when I will scroll down the question number 2, 3, and 4.
Sure,
So
sir.
the first question for our participant, which of the following is not a mechanism for hyperglycemia in patients with subclinical hypothyroidism? Increase in gluconeogenesis, decrease in insulin secretion from beta cell, increase in leptin secretion, increase in free fatty acid.
Sir, next.
Question 2, which of the following complication is less compared to others in patients with diabetes mellitus and subclinical hypothyroidism? Neuropathy, nephropathy, retinopathy, coronary artery disease. Which of the following complication is less compared to other in patients with diabetes mellitus and subclinical hypothyroidism?
Sir, next.
T3 and thyroid binding globulin seen in which time in pregnancy? It is the 8th week of pregnancy, 12th week of pregnancy, 16th week of pregnancy, 20th week of pregnancy. peak T4 and thyroid binding globulin seen in which time in pregnancy?
Next one.
For the recent published data in the prevalence of congenital hypothyroidism in India is it is 1.1 is to 1000, 2.1 is to 1000, 3.1 is to 1000, 4.1 is to 1000. So the prevalence of congenital hypothyroidism in India as per the recent published data.
So next one.
For the WHO 2022 thyroid cancer classification, which of the following is classified under low risk malignancy? PTC, FTC, NIFTP, oncocytic adenoma. PTC, papillary thyroid cancer, follicular thyroid cancer, non-invasive follicular type with papillary presentation, oncocytic adenoma.
So next one.
Refractory hypothyroidism means a dose requirement of thyroxine more than 1.7 microgram per kg per day, 1.9 microgram per kg per day, 2.1 microgram per kg per day, or it is 2.3 microgram per kg per day. To say it is refractory hypothyroidism.
So next one.
T4 to T3 conversion not done by propranolol, amiodarone, methimazole, PTU, propylthiouracil. So conversion of T4 to T3 is not done by which of the following? Propranolol, amiodarone, methimazole, PTU.
So next one.
Asperger syndrome consists of which of the following disease? It is hypoparathyroidism plus myasthenia gravis plus celiac disease, or it is adrenal insufficiency plus autoimmune thyroid disease plus candidiasis, or it is adrenal insufficiency plus autoimmune thyroid disease plus type 1 diabetes mellitus, or other autoimmune disease not typical of ASP1.
So next one.
Amount of iodine contained in the povidone iodine is 5 milligram per ml, 10 milligram per ml, 15 milligram per ml, 20 milligram per ml.
So next question.
Last question. Deiodinase type 1 not found in liver, thyroid, kidney, or placenta.
Done.
So over to Vijay sir to start the discussion with the general quiz and announce the winner. Followed by we will discuss about the DM questions and answers, and we will announce the winner.
Sir, we can't hear you. Can you please unmute?
Yes, sir.
Okay, now I'm audible.
Yes, yes.
Yes, sir.
So we'll discuss the practitioners quiz answers first, which was done online before the start of the meeting itself. And to discuss this first, I'll just discuss the answers. Question number 1, which is not the physiological changes in thyroid function seen during pregnancy. So the correct answer is decrease in renal iodine excretion, which is actually increased in pregnancy. Thyroid hormone synthesis is increased. Thyroid binding globule is increased due to estrogen, and HCG stimulates it. All others are correct. So this is discussed in detail in the Navigating Thyroid Disorders in Pregnancy article, which was published in Thyroid Research and Practice, which is the flagship journal of the ITS, where clearly it mentions that increase in renal iodine excretion is characteristically seen in pregnancy. It's not decrease. So TBG is increased, thyroid hormone synthesis is increased, HCG stimulates the thyroid hormone, the TSH receptor. So the answer is the increase in the decrease in renal iodine is the wrong answer. So the prevalence of second question, prevalence of subclinical hypothyroidism more among this population except. So the correct answer is male. All others are risk factors for higher prevalence of subclinical hypothyroidism like female, anti-TPO positive and elderly type 2 diabetes. This also was published recently in the Thyroid Research and Practice Journal a couple of years back, subclinical hypothyroidism in adults from the ITS, which clearly showed that advanced age, female gender, all are associated with higher risk of subclinical hypothyroidism. So male sex is not an increased risk. Third question was, which is not true of thyroid nodule, more common in females? The correct answer is more common with iodine sufficiency. So thyroid nodules are more common with iodine deficiency. This also was published in the May-August issue of the Thyroid Research and Practice Journal, which clearly showed that iodine deficiency is more often associated with thyroid nodules. Next question, number 4, thyroid receptor found in the liver is, correct answer is thyroid receptor beta 1. This also has been discussed in the recent Thyroid Research and Practice Journal, Thyromimetics Hope or Hype, which showed that TR beta 1 receptor is present in the liver. The next question is TR beta, thyroid receptor beta has how many isoforms? Answer is 4 isoforms. Discussed recently in the Thyromimetics Hope or Hype article, which discussed how the thyroid receptor beta has got 4 isoforms. Question number 6, clinical activity score for Graves' disease includes all except. We had an interesting exhaustive discussion on thyroid eye disease. So corneal injection is not there. These are the characteristic features of the clinical activity score. The corneal injection is not there. Only conjunctival edema, swelling, and signs of inflammation. So corneal injection is the answer. Question number 7, which is false regarding Bethesda system of classification for thyroid FNAC? The correct answer is category 2 risk of malignancy is not 8 to 15%. Actually, category 2 is clearly benign, where the risk is only 2 to 7%, which was discussed recently in the Management of Thyroid Nodules consensus statement by the Indian Thyroid Society. Next question was question number 8, mechanism of action of metformin on thyroid axis. Correct answer is decrease the central dopaminergic tone. So there are various effects on metformin which reduces the TSH, and decrease in the central dopaminergic tone is not there. It's actually increased in metformin. Question number 9, on ultrasound criteria suggestive of thyroid nodule malignancy. All are true except presence of peripheral halo. So malignancy, the peripheral halo, the smooth appearance is gone. So usually the absent halo is there. This is published in the recent guideline of the Indian Thyroid Society on thyroid nodules, the consensus statement. Absent halo is a feature of malignancy. Clearly preserved peripheral halo is beta agonist. This also been recently published in the Thyroid Research and Practice. So a lot of new articles and updates are published in Thyroid Research and Practice, requesting all attendees to consider reading these articles, which provide a lot of information. Ritika madam, you have the results for the quiz?
Yes, I'm sharing.
Practitioner's quiz, please share.
Yes.
The winners for the quiz conducted for the practitioners online, Dr. Adarsh Raghavan. Congratulations, Dr. Adarsh Raghavan. Second is Dr. Anuradha. And third is Dr. Manikanta. Congratulations to all the quiz winners, practitioners quiz. We will be received a certificate of appreciation from the Indian Thyroid Society by email. Over to Dr. Ritesh, who will discuss the DM quiz conducted today, the answers for the DM quiz, and he will declare the winners for the today's DM quiz.
Thank you. So, next question for our DM trainees students are, which of the following is not a mechanism for hyperglycemia in patient with subclinical hypothyroidism? So the answer is increase in leptin secretion, because in subclinical hypothyroidism, it is decrease in leptin secretion which is responsible for hyperglycemia. So again, if you go by the article of our Thyroid Research and Practice, it very beautifully explain how this subclinical hypothyroidism is causing hyperglycemia. It is the obesity which cause insulin resistance, increase in free fatty acids, decrease leptin, adiponectin, and increase in resistin, which all responsible for the insulin resistance, increase TSH per se, increase the hepatic glucose production, and decrease insulin secretion. All leads to hyperglycemia. So it is the decreased leptin secretion, not the increased leptin secretion, which is responsible. Coming to the second question, again, which of the following complication is less compared to other patients with diabetes mellitus and subclinical hypothyroidism? So we are not saying that all the complications are there, but which one is less compared to others? So again, a very beautiful flowchart presentation of the subclinical hypothyroidism with type 2 diabetes in our Thyroid Research and Practice, which clearly shows the subclinical hypothyroid with diabetes mellitus, nephropathy, retinopathy, high risk of cardiovascular disease, TPO positive. You need to treat this group of patients if they have subclinical hypothyroidism, nephropathy, retinopathy, high risk of CV disease with TPO positivity. So the less common is the neuropathy we are encountered in our type 2 diabetes patients with subclinical hypothyroid, compared to more prevalence of nephropathy, retinopathy, and coronary artery disease. The third question, peak total T4 and thyroid binding globulin seen in which time in pregnancy? So answer is 16 weeks, and normally it starts getting increasing up at 7 to 8 weeks of pregnancy, and following conception, it is mostly start rising by around 7 to 8 weeks of gestation, and it is peaking around 16 week of pregnancy and remaining there till delivery. So again, the latest article of Thyroid Research, which is giving a clear-cut idea about the recent advances in the thyroid update. Fourth question, as per the recent published data, the prevalence of congenital hypothyroidism in India, it is completely an academic question. So if you see the different prevalence of the hypothyroidism, the currently Indian published data which says the congenital hypothyroid is around 3.1 per 1,000 population. And if the pregnancy is multiple, like if it is twins, the risk is again more, it is 1 in 900. And if there is more than twin pregnancy like triplet or quadruplet, then it is more prevalent at around 1 in every 600 childbirth. As per the WHO 2022 thyroid cancer classification, which of the following is classified under low risk malignancy? So as per the WHO 2022, the thyroid cancer is classified as benign, low risk malignancy and malignancy. So it is clearly seen in our practice journal where oncocytic adenoma is a benign condition. Answer is NIFTP, which is a low risk malignancy, which is a non-invasive follicular type of thyroid with papillary-like nuclear characteristics, and we all know about the PTC and FTC. So the answer for this question is NIFTP, the low risk malignancy as per that classification. The sixth question is the refractory hypothyroidism means a dose requirement of thyroxine more than. So most of the time we are giving or treating our patient with hypothyroidism with a dose of 25, 50, 75. So when you think of refractory hypothyroidism or the requirement of dose above that, you should think of other condition which is responsible. So in an article published is the combination therapy rationale in the management of hypothyroidism in September to December 2024. Persistent TSH elevation despite the daily dose of more than 1.9 microgram per kg per day with compliance is referred to with the refractory hypothyroidism. So in that case, you can think of other condition which is responsible for not responding to the dose of thyroid. T4 to T3 conversion not done by. So a lot of drugs which is mostly hamper the different pathway of the thyroid hormone synthesis. So if you see the TSH receptor, T3, T4 synthesis, conversion, so amiodarone, propranolol, corticosteroid, hyouracil, all are inhibiting the peripheral conversion of T4 to T3, but methimazole group of molecule are not doing the same. So this is the answer for this question. Question 8, Carpenter syndrome, which is consist of. So mostly Carpenter syndrome is an addition to the Smith syndrome, which is the adrenal insufficiency plus autoimmune thyroid disease. So Smith syndrome plus type 1 diabetes is the Carpenter syndrome. So the syndrome of primary adrenal insufficiency with autoimmune hypothyroidism is a Smith syndrome, and the presence of type 1 diabetes in this is the Carpenter syndrome. Again, a very good article published in 2015 in Thyroid Research and Practice Journal. Amount of iodine in povidone iodine is. We all know the different source of iodine we are taking, like SSKI, povidone iodine, contrast agent used in our CT scan and all. So this is the clear-cut table given in our William textbook of endocrinology. Povidone iodine is giving around 10 milligram per ml of the content of iodine in povidone iodine. And the Lugal solution, 6 milligram per drop, SSKI 38 milligram per drop. Last question, deiodinase type 1 not found in. So the answer is placenta, again in the Williams textbook of endocrinology. So the tissue location where you will find the type 1 deiodinase are the liver, kidney, thyroid and pituitary. So it is not in the placenta. So answer is the placenta. And these are the 10 questions what we have discussed, and maximum thyroid updates are available in our Thyroid Research and Practice Journal. So I will also believe we should go through the Thyroid Research and Practice Journal to get the update about the thyroid disease published by our Indian Thyroid Society. So over to Ritika ma'am to declare the discussion and over to organizer to conclude the session.
Yes.
Ritesh, you should stop sharing. Ritesh, you would like to declare the results?
So the winner is Dr. Abhijit, who answered 5 out of 10 questions. Dr. Manita is also 5 out of 10. Second, Dr. Suyas Gupta, third, 4 out of 10 questions. And Dr. Vibhu Ranjan Khare, 4 out of the 10 questions. So as these are the ties, sir, how we will do? We will give.
No, I think tie is depending on how fast they answer, so number 2 is already number 2.
Okay, okay. So it is KVC-like thing.
Yes. Congratulations to all the winners. I think we had a excellent thyroid clinics today. We had a good case presentation by Dr. Ritesh on non-recurrent laryngeal nerve and approach. And this is new to endocrinologists who are non-surgeons, but it was a good enlightenment for us. And we had excellent exposition of thyroid eye disease by an expert who has published a book itself on thyroid eye disease. And we had an excellent quiz by Dr. Ritesh, and the practitioners quiz also response was very good. So we have a lot of articles coming in the Thyroid Research and Practice Journal. So please go through the Thyroid Research and Practice Journal. The next session will be on 12th March 2025. So stay tuned. Over to Dr. Pramila Kalra, the coordinator for ITS clinics for concluding remarks.
Thanks, Dr. Vijay Bhaskar. So thanks, everyone. We had an excellent discussion on all the surgical as well as the medical topics today. And I thank Dr. Ritesh, Dr. Singh, Dr. Rath, and I also thank Dr. Ritesh again. There we had two Dr. Ritesh today for the excellent quiz also. And just to also add that we have our Journal of Thyroid Research and Practice, which is the official journal of the Indian Thyroid Society. So all the faculty and consultants are welcome to become reviewers for the journal, and everybody is welcome to submit their articles to our journal because this is the official journal of the Indian Thyroid Society. And thanks, Dr. Vijay Bhaskar Reddy, for the coordination of the session today. And I also thank Dr. Roma and Dr. Gandhi and Dr. Chitra, who are also the team members for these ITS clinics. And I thank our president as well, who's guiding us for all these sessions. So the next session, as Dr. Reddy has already told, is on 12th March. So please stay tuned and join us for the session. And I thank and I congratulate all the quiz winners also who have won the quiz. You'll all be getting certificate from the Indian Thyroid Society. So please put in your mail ID so that and your phone number so that your certificates can be sent to you. Thank you.
तस्य भासय सर्वमिदं विभाति।